have the privilege of introducing Dr. Jeffrey Silberzweig, who will be presenting on blood pressure management and how it impacts kidney function. He is the Chief Medical Officer at the Rogosin Institute and also leads dialysis programs at New York Presbyterian Hospital as chair of the Dialysis Executive Council. He has been a nephrologist and leader in the community for over 25 years, and we are very excited to have him speak at Hope Week today. So thank you for being here. And with that, Suzette, can you go ahead and bring up his slides? And I will pass it over to you, Dr. Silberzweig.
Thank you for that very generous introduction, Estella. So I was going to talk with you all today a bit about blood pressure management and kidney function, and I think it's actually perfect for me following the chair yoga, which is one of the key ways that can help us relax and in many cases can help lower blood pressure. So what I'll talk a little bit about is why we should worry about blood pressure. Then I'll talk a little bit about how patients can help themselves in terms of blood pressure control. I'll talk some about medication, and then I'll talk a little bit about what to do if you already have kidney problems and have high blood pressure. And finally, I'll talk about blood pressure control for patients who are receiving kidney replacement therapy. So some of you may remember from the 1960s and 70s Mad Magazine and Alfred E. Newman, whose catchphrase was, "What, me worry?" So why should patients with high blood pressure feel well? Most of them generally feel well, but despite that, high blood pressure can do damage. High blood pressure can cause symptoms which may include headaches, confusion, blurry vision, double vision, blood in the urine, nosebleeds, chest pain, shortness of breath, and leg swelling or edema. So what are the issues with high blood pressure? If the blood pressure is between 150 and 160 systolic, that's the top number, you can see here that there's nearly twice as the risk of both heart attack and stroke. And importantly, this risk increases further for patients who smoke tobacco, patients who drink alcohol, patients who are under a lot of stress, patients with diabetes mellitus, those who are obese, and those who have high cholesterol levels. Common complications of high blood pressure include cardiovascular disease, which we define as heart attacks, heart failure, and stroke, as well as kidney disease. And you can see that the impact is there both for systolic blood pressure, that top number, as well as for diastolic blood pressure, the bottom number. So as I mentioned, with systolic blood pressure, the risk doubles when your blood pressure is about 150 to 160, whereas with diastolic, that bottom number, the risk is about double when the number is above 100. So that gives you a rough range of where you are. But even for patients whose diastolic blood pressure, the bottom number is around 90, the risk is nearly 50% higher. And with a top number, around 50% higher with a blood pressure of 140. So even relatively mild high blood pressure can do a lot of damage. So how does blood pressure affect the kidney? Well, blood pressure is the force of the blood against the walls of your arteries. And when the blood pressure is too high, it damages the blood vessels that supply the kidney. Over time, those vessels become thickened, and over more time, that damage leads to scarring, which can be irreversible damage to the arteries and to the kidneys themselves. When the arteries supplying blood to the kidneys are damaged, they can't deliver the full blood supply to the kidneys. That means less blood is filtered, and it also means that the kidneys suffer from not getting enough oxygen and nutrition, and they're damaged further. The relationship between high blood pressure and kidney disease is a vicious cycle. Remember that the kidneys filter about 1/5 of the blood that the heart puts out every minute. Damage to the blood vessels supplying the kidney impacts kidney function, again, because those vessels supply less blood to the kidneys and they receive less oxygen and nutrients, so they can't function as efficiently. Kidney damage can worsen high blood pressure due to fluid buildup or to hormones that raise blood pressure, and we'll talk more about this in a little bit. High blood pressure can also lead to cardiovascular disease, as we've just talked about, which can further reduce blood flow to the kidneys, for example, when patients have heart failure. Kidney disease is recognized as a risk factor for cardiovascular disease. So again, the vicious cycle continues. So getting into some statistics about kidney disease and high blood pressure. High blood pressure affects almost half of American adults. That's more than 92 million people. High blood pressure, as you can see from this graph, is the second most common cause of kidney failure in the United States. Here, high blood pressure causing kidney disease, end-stage kidney disease, is in red. In addition, chronic kidney disease affects more than 1 in 7 adults in the US. That's more than 37 million Americans who have chronic kidney disease. And about 90% of those with chronic kidney disease do not know that they have chronic kidney disease. And obviously, if you don't know it, you can't do anything to protect your kidneys. High blood pressure in patients with kidney disease is a critically important factor. As you can see here, nearly 2/3 of patients who die from when they have kidney failure die from cardiovascular disease. About over 20% of them die from cerebrovascular diseases, which is essentially strokes. More than 20% from sudden death, which means that the heart stops suddenly, and about 25% from other cardiovascular diseases. So more than 2/3 of patients who die with kidney failure die from heart-related conditions. Therefore, the control of blood pressure remains vital even once the kidneys have failed. But blood pressure control may be more difficult once the kidneys fail. As I've talked about, and as I'm sure most of you know, when patients' kidneys don't work, they tend to retain fluid. Some patients have symptoms of fluid overload, which may include leg swelling, shortness of breath, or weight gain. But other patients with fluid overload don't have clear symptoms. And it's important to recognize that high blood pressure can result from fluid overload even in those patients who don't have symptoms. In addition, the failed kidneys often make hormones because of the lack of blood flow. Some of those hormones, like renin and angiotensin, cause the blood vessels to tighten or constrict, which can further raise blood pressure and further reduce blood flow to the kidneys. Importantly, some side effects of some of the medications that we use to treat complications of kidney failure can raise blood pressure. And one example of that is erythropoietin, which is used to treat anemia in patients with kidney disease. So one of the most important things that patients should ask themselves is, what can I do to help myself? So one of the important things that any patient with high blood pressure can do is modify their lifestyle. There are a number of steps that patients can take to help themselves. The first is to exercise regularly. And that doesn't mean you need to be a marathon runner. The goal is to exercise for 2.5 hours a week. And that's ideally spread over 5 or 6 days. So that means exercising for a half hour or less each day. And that exercise can include anything that you enjoy doing. It can be bicycling, it can be swimming, it can be walking, it can be running, it can be any activity that you enjoy. It's also important to maintain moderate weight. Well, what does that mean? The goal is to have normal weight for your height. And there are numerous charts that are available that show you what a normal weight for your height is. Patients who are overweight may benefit from losing as much as 10% of their weight during the first year of treatment for high blood pressure. That's certainly something that you should discuss with your doctor, and you should be careful about these many products that are advertised on TV as causing more weight loss than 10% in a year. That kind of weight loss may actually not be healthy. So again, please talk to your doctor about what's appropriate for you. Keeping stress controlled is an important factor in controlling blood pressure. And activities like meditation, yoga, including the chair yoga that we just did, Tai Chi, exercise, and music all can help control blood pressure. It's really important for patients who have high blood pressure and kidney disease to limit their salt intake to slow the progression of damage to the kidneys. For most patients, sodium intake should be limited to 1,500 milligrams daily. Again, please discuss that with your doctor. And note that on packages of food that you buy in the grocery store, there's a label that shows you how much sodium is in each given product so that you can get a sense of how that product may affect your blood pressure. If you smoke tobacco, do your best to quit, and there are numerous things that your doctor can do to help you with that. There are medications that you may be able to take, there's gums, there's things like that, and therapy may be able to help you as well. Limit your alcohol intake. Some people are advised that they can drink up to a glass of wine or one drink per day, but again, please consult your physician to know what's appropriate for you. In terms of looking for complications of your high blood pressure, it's really important to see your physician or provider regularly. A good physical exam will test for signs of stroke, heart attack, or kidney damage, and can even look for signs that you're at risk for those complications. An EKG or electrocardiogram is a quick, easy, and painless test that can detect for heart problems. Tests for kidney damage may include tests of both blood and urine. As everybody on this call I'm sure knows, elevations of BUN and creatinine on blood tests indicate kidney damage, but that damage may not be seen until there's already significant damage present to the kidneys, and we'll talk more about that in a little bit. Urine tests for protein in blood may show damage earlier, and this picture illustrates how damaged kidneys end up with different looking urine. So in normally functioning kidneys, blood and protein, which is represented by the dark circles here, stay in the blood and don't end up in the urine. But when the kidney is damaged, albumin, which is the blood protein, and blood can leak through the damaged filter of the kidney and end up in the urine. Initial screening tests can be done in a laboratory or in a doctor's office, but further evaluation by confirmatory tests usually require collection of urine for a whole day, so that usually needs to be done at home. Other tests that may look at your kidneys include ultrasounds, X-rays, CAT scans, or MRIs. So now I'm going to talk a little about medication that can help you control your blood pressure. As you all know, there are many medications available to treat high blood pressure. Importantly, only about half of people who are treated for high blood pressure achieve good blood pressure control. As everybody knows, all medications have side effects, so that some patients may actually feel worse when they're taking medication than when they don't take the medication. So it's really important that you talk with your physician or your provider about any symptoms that you may feel, because the doctor will have alternative medications and may be able to help manage some of the symptoms so that your blood pressure can be better controlled. It's important to realize that there's a real risk of untreated high blood pressure. This figure, which is taken from the Centers for Disease Control and Prevention, the CDC, shows that a reduction in blood pressure by 12 or 13 points can reduce the risk of stroke by more than a third, the risk of coronary artery disease, which is heart attacks, by more than 20%, the risk of death from cardiovascular disease, which, as we talked about earlier, is strokes, heart attacks, and sudden death, by 25%, and the overall risk of death by more than 10%. So it doesn't take a whole lot of blood pressure control to improve your health. So what is the best medication for any patient? Well, it really depends on each patient's particular characteristics, which have to do with genetics and what other medical conditions that patient may have. Because there are so many different medications available, it may require trial and error to find the medication that has the fewest side effects and is most effective for any individual patient. Many patients require more than one medication to control their blood pressure, and some require as many as 4 or 5 medications. Don't get frustrated with this process, because in the end, it's worth the effort of finding medications that are right for you. Some medications that are frequently prescribed for patients with kidney disease include ACE or angiotensin-converting enzyme inhibitors like lisinopril and enalapril, or angiotensin receptor blockers like losartan and valsartan. So what if you already have kidney damage? Is it too late? So first I want to talk a little bit about how we measure kidney function. As everybody knows, The kidneys form urine by filtering the blood, and they ultimately eliminate excess fluid and waste products like urea and potassium. Really, what we think about when we look at kidney function is how the kidney filters blood. That's sometimes referred to as the glomerular filtration rate, which is represented by the numbers that you see on the left-hand side of this graph. There is, however, no direct test for GFR, or glomerular filtration rate, so it's estimated most commonly through measurements of creatinine in the blood, which you can see across the bottom of this figure. It's important to realize that creatinine is not an ideal test for the measurement of kidney function of GFR. As you can see here, by the time creatinine levels become abnormal, which is a creatinine level greater than 1.5, somewhere between 25 and 50% of kidney function is lost. In addition, creatinine levels depend on the age and size of an individual patient. Since creatinine is a breakdown product from muscle, obviously the more muscle that you have, the higher your creatinine level will be, so that some patients who are very muscular will have normal creatinine levels even as high as 1.5, 1.6, or even a little bit higher. And some very small patients will have abnormal kidney function even with a creatinine level as low as 0.5. So we've tried over the years to better understand how routine blood tests can translate into GFR. One thing that we can do is to measure GFR more directly. Typically, the test that's done is creatinine clearance, and you can see the creatinine clearance up along the side of this graph. Measuring creatinine clearance requires collecting the urine for 24 hours. Unfortunately, that's quite cumbersome to do. As you can imagine, and those of you who have done it know, when you collect your urine, all of your 24-hour urine at home, it requires having a bottle next to the toilet and remembering to put all of your urine into that jug. Unfortunately, many patients who collect 24-hour urines will forget to put some of the urine in the jug, and therefore inaccuracies are common. And I've unfortunately seen that many times, even in patients in the hospital, where they can be observed directly by nurses, because sometimes they'll just have to go, it's an emergency, and they forget to put the urine in the jug, or they'll urinate into a urinal or a bedpan, and some of that urine gets spilled. Sometimes the nurse begins collecting and forgets what time they started the collection, so it may last for only 23 hours or for 25 hours, and that can lead to inaccuracies as well. As you can see in this figure, the results of creatinine clearance are different for men and for women, even when the creatinine numbers are the same. Additionally, again, because creatinine is a breakdown product from muscular patients will have more creatinine. That leads to a higher creatinine level and a higher creatinine clearance. Changes in muscle mass due to aging cause changes in creatinine clearance. And as you can see here, with the same creatinine clearance, the same amount of creatinine in the urine, the estimated the creatinine clearance number calculation will decrease as you age. And that's true, obviously, both for men and for women. In addition, there are some medications that interfere with the test of creatinine, including cimetidine, which is a medication used to treat acid buildup in the stomach, trimethoprim and pyrimethamine, which are antibiotics, and aspirin derivatives like salicylates, all interfere with creatinine secretion. So for many years, we've used formulas to calculate GFR. The first formula that was developed was the Cockcroft-Gault formula, which was developed in the 1970s from a Veterans Affairs hospital population that consisted almost entirely of white men. The formula for calculating creatinine clearance is based on ideal body weight, which few of us have. At lower levels of GFR, as you can see here, the difference between the measured and the calculated creatinine clearance becomes more important. As you can see, when for the same observed GFR of 60, patients might have calculated creatinine clearance that ranges between 40 and almost 100. And so where that patient is accurately can affect what stage of CKD they are thought to have. And that can certainly affect decisions about things like preparing for dialysis or a kidney transplant, certain medications that may be beneficial or harmful to the kidneys. It can affect decisions about whether radiology studies or cardiology studies should be done because of the risk of worsening kidney function. So, a simpler, more precise tool is needed. In the 1990s, the modification of diet and renal disease, or MDRD study, was conducted in 2,000 patients with chronic kidney disease. The study was set up to evaluate the benefits of dietary protein restriction on patients with chronic kidney disease and to see if restricting dietary protein slowed kidney disease progression. Side note is that there was not a significant difference with protein restriction, and in my own practice, I generally do not recommend protein restriction except in the small number of patients who really are not going to go on dialysis, either because they anticipate getting a kidney transplant or because they have such severe conditions beyond their kidney disease that there's little benefit for them from dialysis. But for most patients, restricting protein doesn't really benefit them, and it can lead to more complications when they're on dialysis or have a kidney transplant. The modification of diet and renal disease study included patients with both sexes and with different races. All of the patients in the study had GFR measured directly by specialized tests and had 24-hour studies for the measurement of creatinine clearance. And this table taken from the publication about that study shows the relationship between various measures of kidney function and direct measurement through the GFR. So this is 1 over the serum creatinine. So essentially looks at the relationship between creatinine and GFR. And you can see that the correlation was 0.65. So it was good, but a correlation of 1 would be a perfect correlation. So clearly not great. The relationship with BUN was much worse at 0.25. This is another test that looked at urea, was 0.5. The formula, which we'll talk about in a few minutes, the MDRD study equation, had a correlation of 0.71. The measured creatinine clearance had a correlation of 0.72. And finally, the Cockcroft-Gault formula had a correlation of 0.68. So you can see that these 3 tests all performed similarly in this population. The estimate of GFR that came out of this study, the MDRD estimate, employed 6 values: the serum creatinine level, the serum albumin level, which is a measurement of the blood protein levels, the BUN, the patient's age, race, and sex. And what they showed is that these relationships, or this measurement, this calculation, had a good correlation between measured and estimated GFR. At higher levels of kidney function, the estimate is less accurate, which is not really surprising because, again, all of the patients enrolled in this study had abnormal creatinine. They all had chronic kidney disease and abnormal GFR. So they didn't have patients in the study who had normal GFR or normal creatinine levels. The inaccuracy at higher levels of GFR is less important because most of these patients are in very early stage CKD, and so the decisions made based on it will generally not affect patient management. However, at lower levels of GFR, the inaccuracy becomes more important. When you look at patients who had measured GFR of 30, you can see that the estimated GFR actually came out to between 20 and as high as 60. So that means that some of these patients were believed to have or were diagnosed with stage 4 or even stage 5 chronic kidney disease, and others with stage 2 or stage 3 chronic kidney disease. Importantly, for patients who were identified as Black, the inaccuracies at all levels of GFR, as you can see here, were much greater. And that led to a lot of thought, particularly in the last 5 years or so, about the differential impact of these inaccuracies on patients with kidney disease. And it was noted that elimination of these biases would improve health equity and social justice, because race is a social but not a biological construct. From this figure, you can see the effect of removing race from the estimates of GFR. Patients in orange or red here are those in whom recalculating the GFR without that race correction factor would change the estimate of GFR. As a result of removing race from the calculation, the prevalence of chronic kidney disease increased by as much as 5%. In other words, 5% of patients who might have been told that they had normal kidney function previously were now told that they had chronic kidney disease. Up to 30% of patients who were previously diagnosed with chronic kidney disease were reclassified to a worse stage of CKD. This mostly affected patients with stage 3A CKD who were later classified to stage 3B, so didn't necessarily mean that patients ended up needing a dialysis or a transplant sooner. The benefits of earlier recognition of CKD meant that patients were provided education about chronic kidney disease and about their treatment choices at an earlier time. And patients were referred for evaluation for kidney transplants sooner, which meant that many of those patients were then able to get transplanted, and some didn't need to go on dialysis at all because they were transplanted. Blood pressure, again, causes kidney disease, as we've seen, but kidney dysfunction also causes high blood pressure. As kidney function gets worse, it can be more difficult to control blood pressure. Normal blood pressure control goals, or blood pressure control goals, depend on how much proteinuria, how much protein a patient has in their urine. For those who don't have significant proteinuria, normal blood pressure, that is a blood pressure less than 130/80, is considered adequate. But for those who do have protein in their urine, tighter blood pressure control is needed, and the goal is set at 120/70. The inability to control blood pressure to these goals is associated with faster decline in GFR and higher risk of progression to end-stage kidney disease. In this graph, renal outcomes, this shows the proportion of patients who had renal outcomes, which were defined as a doubling of the creatinine level or progression to end-stage kidney disease. Sorry, a 40% decrease in GFR, progression to end-stage kidney disease. And you can see how for patients with blood pressure less than 130/80, there was a much lower occurrence of that renal outcome. So how do medications help with blood pressure control? Again, the choice of medication depends on a lot of factors, including whether patients have protein in their urine or not. For those who have protein in their urine especially, angiotensin-converting enzyme inhibitors and angiotensin receptor blockers are first-line medications and should be tried before other medications. For those who either can't tolerate these medications or whose blood pressure is not adequately controlled, or for those who don't have protein in your urine, other medications like calcium blockers and diuretics may be indicated. There are some new medications available, which is really good news for patients with kidney disease. Among them are SGLT2 inhibitors. Dapagliflozin and canagliflozin are new medications that have recently become available and have been shown to be very beneficial, particularly for patients with diabetes and heart failure and patients who have kidney disease. These medications have been shown to slow or reduce the progression of both heart disease and kidney disease in these patients. They may also lower blood pressure a little, so they often need to be combined with other medications in order to achieve the type of blood pressure control that we've been talking about. So what happens once a patient is receiving kidney replacement therapy? Patients who need dialysis can't eliminate enough water, salt, and waste products on their own. This leads to increased fluid in the body and increased blood pressure. In addition, the buildup of waste products like phosphorus contributes to arterial stiffness and endothelial dysfunction. And you can imagine that when phosphorus, particularly coupled with calcium, deposits on the inside of an artery like this one, which is pictured here, it thickens the blood vessel and puts more pressure on that artery. There's the same amount of blood flowing through a narrower space. The kidneys also continue to make hormones like renin and angiotensin, which raise blood pressure directly and activate the sympathetic nervous system. And we all know that when we get anxious, our heart beats faster, and that raises blood pressure. In addition, as I talked about earlier, medications that are used to treat anemia, the erythropoiesis stimulating agents, or erythropoietin, Aranesp, darbepoetin, Epogen, medications like that, are also known to raise blood pressure. What about patients who are on dialysis? Many patients who are treated by dialysis have highs and lows in their blood pressure, and these highs and lows are associated with an increased risk of death. And you can see what happens to many patients who are on dialysis. When they go to dialysis, their blood pressure starts out high, they get fluid taken off during dialysis, and after dialysis, their blood pressure is low. Over the next 2 days before the next dialysis treatment, they gain fluid and the blood pressure goes up. And they have this up and down or seesaw pattern to their blood pressure. But when we look at home dialysis treatments, and this graph is from patients on peritoneal dialysis, but the same is true of patients who do hemodialysis at home because they tend to treat more frequently. Patients on PD, in purple here, have less low blood pressure and less high blood pressure than those treated by hemodialysis in red. That smoother blood pressure control is associated with less risk of death, lower risk of heart attack, and lower risk of stroke. What about patients who have kidney transplant? High blood pressure after kidney transplant causes complications like transplant failure. And here you can see the percentage of grafts, that is transplants, that are functioning at different levels of blood pressure. And you can see that at the lower levels of blood pressure, more transplants are functioning. And as the blood pressure goes up, fewer transplants are functioning. And again, in patients with kidney transplants, there's an association between the degree of blood pressure control and the risk of death. And here you can see that that's true both for systolic blood pressure and diastolic blood pressure. So again, both for the top number and the bottom number. A little bit more detail on factors that cause high blood pressure in patients with kidney transplants. So if there's a problem with the kidney, transplant rejection, delayed graft function, that can lead to immunological factors that raise blood pressure. Immunosuppressive medications like cyclosporin, tacrolimus, and prednisone can also raise blood pressure, but obviously have really important effects at protecting that kidney from rejection. For patients who receive a kidney from someone who had high blood pressure or a family history of high blood pressure, that can be associated with high blood pressure after the transplant. In addition, transplant renal artery stenosis, narrowing of the artery supplying blood to that transplanted kidney, can raise blood pressure as well. For the recipient of the kidney transplant, if that person had high blood pressure before the transplant, they're more likely to have high blood pressure afterwards. If they take a lot of dietary sodium, as we talked about before, they're more likely to have high blood pressure. Metabolic syndrome, which is obesity, poor blood sugar control, high cholesterol, is associated with high blood pressure. Again, transplant renal artery stenosis. Sleep apnea, which is OSA, obstructive sleep apnea, is associated with high blood pressure. The failed native kidneys, if they're still in the patient's body, can continue to secrete hormones like renin and angiotensin, which can raise blood pressure, and again, sympathetic overactivity. Finally, for patients who have recently had transplants, they're often given fluid during the surgery, and again, the transplant renal artery stenosis can raise blood pressure. So I'll stop there, and I'm happy to take any questions that the audience may have.
Thank you so much. That was such an informational presentation. We do have 2 questions for you, or maybe 3. So first question we have, is it possible to obtain normal blood pressure without medication once diagnosed with CKD?
So some people can. A lot of it depends on how high the blood pressure started. But with those lifestyle modifications, patients can frequently reduce their blood pressure by as much as 15 or 20 points. So if your blood pressure was, say, 150 over 80 or 150 over 90, with lifestyle medications, it is possible, or with lifestyle modifications, it is possible to normalize your blood pressure.
Great, thank you. Next question we have, my blood pressure can go up and down by 40 points during dialysis. Is this a problem? Anything that I can do to reduce these ups and downs?
Yeah, so it's a great question. It's a little hard to answer specifically without knowing details about you. But as you know, fluid removal is the factor that causes the biggest drop during dialysis, and tends to cause blood pressure to be the highest at the start of dialysis. So if you can restrict the fluid that you take in between dialysis treatments, your blood pressure is likely to have less fluctuation during dialysis. Other factors that can reduce the ups and downs include longer dialysis treatments. So if your dialysis treatment is less than 4 hours, a longer dialysis treatment can help with that. Sometimes if the machine is turned down to a cooler temperature, that can help to control the fluctuations in blood pressure as well. As we all know, when we go outside on a cold day, we shiver, and that shivering actually helps to raise blood pressure. So being a little cool on dialysis can help. I'd certainly urge you to discuss this with your kidney doctor, because there are sometimes medications that may be appropriate, but obviously I can't recommend that without knowing you.
Great, thank you. And then we have a question from Kathleen. She says, very informative presentation with excellent slides. Her friend is on lisinopril and her blood pressure is not well controlled. She is not on a diuretic and her nephrologist increased her dose and she can't tolerate this new dose. Do you have any thoughts? And she says, thank you.
Sure. So first, thank you. I appreciate I'm glad that you enjoyed the presentation. Hard to talk specifically about your friend because obviously I don't know her. If she's not tolerating the dose of the higher dose of lisinopril, I'd certainly encourage her to talk with her doctor about that. A diuretic may certainly be an appropriate medication. The SGLT2 inhibitors that we talked about may be appropriate for her. So those are just a couple of options that she may have. Some patients who don't tolerate high doses of medications like lisinopril may do better with angiotensin receptor blockers, so that may be an option as well. Again, there are a number of options that may be available, and I'd encourage her to talk with her doctor or his doctor to find out what's best for them as an individual.
Great, thank you. And then we have one more question. Is chlorthalidone a good medicine for keeping blood pressure down? I'm sorry if I said that wrong.
No, you said it perfectly fine. Chlorthalidone is a diuretic, and it's a very effective medication. It depends on the individual. It may or may not be enough by itself. Most patients who are on diuretics like chlorthalidone are also told to restrict their salt intake, their sodium intake. So together, that can often be enough to control blood pressure.
Great. Well, thank you so much for your great presentation and your thorough answers. It's been great having you present with us at Hope Week. Any final thoughts before we continue on to our next presenter?
I would just encourage everybody, controlling blood pressure is not easy, but it certainly can be done. And talk with your doctor, and any of us who are available are happy to help in any way that we can.
Great. Thank you so much, Dr. Silberzweig, and we will go ahead.
And a shout out to our corporate mission partners for making this happen.